Assalamu alaikum, everyone. Is my voice clear?
Yes, it is.
Walaikum assalam. Yes, Dr. Kamal, your voice is very much audible.
Okay, amazing. So, heads up before we start today's session. Since this is going to be a longer session than our usual ones, we are going to go at a slightly faster pace because we have to cover quite a lot. We have to go over astrocytomas, oligodendrogliomas, and then we have to move towards the glioblastomas. So, bear with me because the pace is going to be fast and it might not be as interactive as our usual sessions. I have also omitted a few cases because it would take a lot longer if we were to go through the same case-based method that we used in the first two sessions. So the first two slides, the presentations are going to be review. The third one is going to be a continuation of where we left the glioblastomas. So is everybody on the same page?
Yes.
Okay, amazing. So let's begin. Fasten your seatbelts because we are starting. Okay, so my screen is visible, I hope.
Yes.
We initially started this as a series on adult diffuse gliomas. We are going to briefly cover the astrocytomas first. And the entire classification begins with one gatekeeper question. Is the tumor IDH mutant or is it IDH wild type? So this is a brief overview of the classification. When we get a tumor sample, we run it, the first test that we run it through is the IDH mutation. If it is positive, then it goes into the IDH mutant tumor group. If it is negative or IDH wild type, then it is automatically classified as a glioblastoma. So the tumor group in which IDH mutation, either one or two, if it is positive, the next test that we need to run is 1p19q co-deletion. If this is positive, this is going to be an oligodendroglioma. If 1p19q co-deletion is not positive, then we are going to check for ATRX expression and TP53 mutations. Their deletion is going to lead to the diagnosis of astrocytoma, IDH mutant. So, obviously, as I have just gone over this, IDH mutation is present. There is no 1p19q co-deletion. There is ATRX loss and TP53 mutation. These are the two most important mutations that support the astrocytic lineage. These tumors are then further graded into grade 2, grade 3, or grade 4. And okay, so these are deep white matter tumors that infiltrate the brain parenchyma, destroying it in the process. And they like supratentorial compartments, usually near or within the frontal lobes. The grade 2 usually favors temporal lobe, grade 4 favors frontal lobe, but you can find them anywhere in the supratentorial compartment. Infratentorial compartment can be involved in some cases, but is generally not favored. So, how would you differentiate grade 2 from grade 3? Can somebody from the listeners comment on this?
Yes, ma'am. In grade 2, there is only there is no anaplasia, no microvascular proliferation, no necrosis. But in grade 3, there is anaplasia and microvascular proliferation.
Okay, there is one more thing that you're missing. What about mitotic activity?
Yes, ma'am. Mitotic activity is present in grade 3.
Right. So, increased cellularity and nuclear atypia is present in both, but grade 3 has significant mitotic activity in comparison with grade 2. When would you classify it grade 4?
When there is necrosis, microvascular proliferation, with or without pseudopalisading, then there is grade 4.
Excellent, Dr. Mustafa. There is another recommendation on the molecular level. What is that?
IDH wild type.
But we are talking about IDH mutant tumors, aren't we?
IDH mutant
So,
mitosis.
Dr. Mustafa was very right about the first criteria. We either grade it on the basis of histologic features, which are microvascular proliferation or necrosis, or there is homozygous deletion of CDKN2A or CDKN2B, even if there is a lower grade on histopathology. And please remember this thing because this is not going to leave you alone, even when we talk about oligodendrogliomas. Homozygous deletion of CDKN2A or CDKN2B biologically upgrades the tumor to the next one. If it is astrocytoma, it is grade 4. If it is oligodendroglioma, it is grade 3. So I have taken out the other cases that we discussed in the first session, but this was an interesting one, so I kept it. This is the case of a 27 years old right-handed man who presented with 2 episodes of focal seizures involving the right hand with preserved awareness. Neurological examination is completely normal. MRI brain shows this lesion here, and I won't comment on the imaging. It's visible to you all. So take a good guess. What do you think? This is a high-grade lesion or a low-grade lesion?
Seems to be a low-grade lesion, but
Okay, how would you
definitely we
justify
can
that?
because there is no central necrosis and there is a lot of edema, but no central necrosis, and it's well circumscribed.
Okay, you are right in how you interpreted the radiology, but the key takeaway that should be taken from this session is imaging alone is insufficient to define the tumor biology. Imaging can be very, very misleading when we are talking about the diffuse gliomas. There are lesions that might appear as low grade on the radiology, but these tumors may still harbor aggressive molecular features. There are tumors which will not show any contrast enhancement, but they would still appear as hot spots on PET. So, imaging alone is insufficient. And as I mentioned, PET helps us identify malignant foci, and it also improves the pre-op risk stratification. So, what is the goal of surgery in a young asymptomatic patient? Say that you receive a young patient in your clinic, and he's probably a 32, 33 years old male, and he's currently asymptomatic. The lesion is non-enhancing. This is the same lesion. It's non-enhancing on post-contrast images, and you don't also see central necrosis, even though I think there is a bucket here. But what is your approach going to be in such patients who is not very symptomatic, whose quality of life is currently okay? How are you going to approach that patient?
So initially, what we want to do is establish the diagnosis, the histopathological diagnosis. So if the stereotactic biopsy or the frameless biopsy is available, so our goal should be initially to biopsy that lesion. Now, after histopathology comes and it's a low grade, so we can follow that patient with series, follow that patient over the time. But if it's a high grade, then we definitely need he would or she would need a cytoreduction.
Okay, Dr. Hamad, that was a very good shot at management strategy that was very relevant a few years ago. But the newer guidelines have changed the strategy quite a lot, as we will see when we go along this session. The goal is maximum safe resection, even in these patients, not biopsy or debulking alone. Why? Because extent of resection is a major determinant of progression-free and overall survival, even in low-grade astrocytomas. Plus, there is another thing which is called de-differentiation. If you are leaving a low-grade tumor in there, it can de-differentiate, or what we call the malignant transformation, in a few years, and then it's going to be a bigger problem to deal with. Also, maximum safe resection provides adequate seizure control, and as I already said, it delays malignant transformation. So we are going to come to the guidelines that kind of overlay how to manage such patients. But first, we are going to briefly overview the radiology. Can somebody read the CD?
Yes, ma'am. There is a 3 to 3 centimeter hypodense area in the left frontal lobe of the axial cut of the CT scan.
Yeah, this is ill-defined. It also shows some mass effect. There is a very early midline shift here and effacement of the lateral ventricle on the ipsilateral side. So on CT, these lesions are isodense to hypodense regions, which are ill-defined, and usually they do not enhance. On MRI, on T1, we are going to have isointense to hypointense lesions compared to the white matter. On T2 and FLAIR, there is going to be a very specific sign. On T2 gliomas, especially astrocytomas, they are going to be hyperintense, ill-defined mostly, and can show perilesional edema, but they will show T2 flare mismatch if the lineage is astrocytic. What is T2 flare mismatch? Can anybody take a shot?
Yes, ma'am. If the lesions which are hyper intense on T2, but they should be hyper intense on flare image, but in T2 flare mismatch, they are hypo intense on flare image.
Excellent, Dr. Mustafa. So, yes, the lesions on when the lesions that show T2 flare mismatch are hyper intense on T2, but when you see the corresponding lesion on flare, there is going to be central hypointensity. The peripheral rim is still going to be hyper intense, but you will see that centrally the lesion is going to be hypointense. This is called T2 flare mismatch sign. It's a very good sign to differentiate astrocytomas and oligodendrogliomas, especially when they have other overlapping features. So enhancement is variable and unreliable for grading, as we have already discussed. Absence of enhancement does not exclude higher grade astrocytomas. Absence of proof is not the proof of absence. This is a chart from Greenberg. I'm sure most of you would be familiar with it. And we can see the typical radiographic findings, which are summarized here. Astrocytomas usually, grade 2, usually do not show a lot of enhancement. Grade 3 might show complex patterns of enhancement. Grade 4 usually show solid enhancement. So these are the NCCN 2025 guidelines, which determine how we manage any patient. So if it is a low-grade lesion, even on the imaging, the first goal is maximum safe resection. After maximum safe resection, if age is less than 40 and we are sure that we have done gross total resection, then observation with MRI surveillance is adequate. If age is more than 40 or subtotal resection is done or the tumor is still symptomatic, then we are going to go for radiotherapy followed by adjuvant chemotherapy. And chemotherapy options have both PCV and temozolomide. So, does anybody remember from the initial sessions what is vorasidenib?
In that cases we do the, if we want to do the temporizing measures, then we give the patient orally IDH 1 or 2 inhibitor vorasidenib.
Yeah, that's right. So vorasidenib is exactly how Dr. Mustafa put it. Vorasidenib is used as a temporizing measure or in patients where we are preferring watchful waiting and tumor is not progressing, or for some reason we are delaying the chemoradiotherapy. For example, patient developed postoperatively infection or any flap complications, or he was unfit for chemotherapy. So in those patients, we use vorasidenib as a bridge. It does not replace the chemotherapy or radiotherapy. So for astrocytoma, IDH mutant grade 3, we have
Dr. Kamal, could you
GG.
please repeat? I'm really sorry for interrupting you. Please repeat what's that thing again.
Okay,
मुझे ये समझ नहीं लगी.
sure. So vorasidenib is an oral IDH1 and 2 inhibitor. It is the first of its kind that can cross the brain now, blood-brain barrier, and we use it when there is some residual tumor or when there is recurrence. and the tumor is not grossly symptomatic, we are choosing to hold the radiation for some reason. Or, for example, you have operated a patient who developed some complications like delayed wound healing, like flap necrosis, and in these patients, you cannot directly move towards radiotherapy or chemotherapy. These patients or this group can benefit a lot from vorasidenib because it is going to hold the tumor static and also slightly decrease the tumor load. So it preserves neurocognition and it serves as a temporizing measure while the patient is waiting for chemo and radiotherapy. Am I clear, Dr. Burhan?
जी जी, थैंक यू वेरी मच मैम। ये ग्रीनबर्ग में ये है, इसका जिक्र है
नहीं,
या ये न्यू
Greenberg में नहीं है. This is new, and
नॉवल
we are
नॉवल?
going to come across quite a lot of new things. Glioma is moving at a very fast pace. So, grade 3, radiotherapy followed by adjuvant chemotherapy with PCV preferred or temozolomide as an alternative. And grade 4. So, the previous STOOP regime did not differentiate patients on the basis of KPS. The new NCCN guidelines that were presented in 2025 do differentiate the treatment. So, any patient who has a good KPS more than 60, and for them, we are going to follow the standard STOOP regime. For patients who have poor KPS, less than 60, we are going to go for hypofractionated radiation or temozolomide alone or only the best supportive or palliative care. So, temozolomide is an excellent drug, but it does have a dark side. TMZ treated recurrences behave like biologically upgraded tumors. There are quite a list of mechanisms, and it was beyond the scope of such a brief session to cover the entire mechanisms. I have only included the most important one. There's a thing called the survivor's training, what temozolomide does to the cell. So the normal response of any cell is when it sees the DNA damage, it commits suicide, which we call apoptosis. What happens in TMZ treated cells is that some cells survive the damage. These surviving cells learn to tolerate the broken DNA. Think of them as handicapped cells, but they go on living, they do not die. Instead of dying, they continue to divide with damaged genes, leading to a tumor that is no longer responsive to DNA damaging treatments. It also causes MGMT reactivation and selection of stem-like cells for gliomas. So, this was an interesting case, and that is why I preserved it instead of taking it out. This is a teenage patient with a diffuse glioma, grade 2, and reported as IDH wild type. Now, do you run the adult GBM molecular panel by habit? Or pause and ask yourself, what does a 16-year-old's glioma actually want me to test? Can somebody answer
Yes,
that?
ma'am. Yes, ma'am. We definitely go for the all the molecular testings, like the TERT promoter gene mutation and the epidermal growth factor gene amplification, and the MGMT
Okay,
status.
but that is the adult molecular panel. We are talking about a teenage patient, is 15, 16 years old, male, for example.
Yes, ma'am. K27M mutation for the midline region that is most commonly found in the childhood, and the MIB Ki67 index.
Okay. Good shot at the end. Yes, we do get the MyB or MyBL1 testing done. We get the S3G34 testing done, and we get the FGFR testing done when the presenting patient is a teenager. Why? Because even if it is IDH wild type, if there are MyB or MyBL1 alterations, diagnosis is pediatric type diffuse low-grade glioma. If there is FGFR alterations in conjunction with IDH wild type, it is still a pediatric type diffuse low-grade glioma. But if in conjunction with IDH wild type, we have H3G34 mutants, then this is a grade 4 pediatric type high-grade glioma. So it is very important to remember that early young adults and the teenage group might present some challenges of their own in terms of molecular profiling. Moving on to oligodendrogliomas. Are we clear? Does anybody have any question regarding this?
So, these pediatric gliomas, which we have just mentioned, diffuse midline glioma, the low grade and high grade group both, they occur mostly in the posterior fossa or in the supratentorial region. Talking about
No,
these.
some of these do occur in the supratentorial region. I grossly remember S3G34 variant. The rest of the pediatric type diffuse gliomas will be discussed in a separate session because they deserve a space of their own. And not all pediatric gliomas are infratentorial.
Okay.
So, moving on to oligodendrogliomas. A 40 years old patient with a frontal lobe diffuse glioma undergoes subtotal resection. The molecular testing shows it is an IDH mutant tumor. Patient receives chemotherapy and improves. The question is, why do oligodendrogliomas show exceptional chemosensitivity compared to astrocytomas?
Because they all are IDH mutant, and there is the MGMT promoter gene methylation. Therefore, there is the excellent effect of the temozolomide or all the alkylating chemotherapeutic agents.
Dr. Mustafa, I'm very glad that you have remembered almost everything we discussed in the first session. Oligodendrogliomas are highly chemosensitive because 1p19q co-deletion leads to loss of DNA repair capacity. And these cells often have significantly lower basal MGMT activity than astrocytic tumors. MGMT is the tumor's defense mechanism. It's like the first line defense mechanism of tumor cells. If the activity is lower on the baseline, these tumors or these cells are automatically going to be more susceptible to the chemotherapy. So, case 2, this is a relatively simple one. A 37 years old right-handed man with well-controlled focal seizures has a slowly enlarging left frontal insular diffuse glioma. Intra-op mapping shows inconsistent language disturbance, and resection could be extended further, but with uncertain functional risk. So, although guidelines recommend maximum safe resection, the debate is how aggressive safe should be in oligodendrogliomas involving eloquent cortex. How aggressive you are going to be and how safe is too safe.
Yes, ma'am. We definitely save the eloquent cortex because the neurological deficit was very worst after the surgery.
Yeah, safe is most definitely defined by functional preservation, and more so in oligodendrogliomas because these tumors are chemosensitive and radiosensitive. So even if we leave certain stuff behind, we still can go back with the adjuvant therapy and get it under control. Any new post-op deficit is a poor prognostic factor. And defining resection boundaries is a double-edged sword because extent of resection is a direct indicator of how well the prognosis is going to be. But if you resect too much and cause a new post-op deficit, then it is going to decrease the survival automatically. So it's good to remember that we resect tumors, not patients' futures. So going over the common resection margins, we have GTR, gross total resection, we have near total resection, we have subtotal resection, and we have supratotal resection, which is a newer concept. So GTR is complete removal of all MRI visible tumor. If it is an enhancing tumor, then we have to take out all the enhancing portion. If it is a non-enhancing tumor, then we have to take out all the hyperintense portion on T2 or FLAIR. And operationally defined as more than 98 to 100% resection. So near total resection is the same thing, but we leave minimal residual disease around the margins, especially if the margins are eloquent. And residual may be non-enhancing or a thin FLAIR signal. Subtotal resection is typically less than 90%. There's significant residual disease, and this is often chosen when the cortex we are dealing with is eloquent. There is deep extension or infiltrative margins. Supratotal resection is a newer concept. It is associated with improved progression-free survival, and this means that we are going to remove the tumor. Along with that, we are going to take out the peritumoral flare zone. And this is only feasible when obviously the lesion or the pathology is in non-eloquent cortex. So as I said, we resect tumors, not patient's features. Moving on to ODGs. As we have discussed the classification briefly in the beginning, these are IDS mutants, 1p19q co-deletion is present, ATRX expression is retained, TP53 is wild type, and these tumors are graded 2 and 3. So, ODGs are cortical or subcortical tumors. They calcify and expand the cortex rather than destroying it. And they often start in the cortical ribbon below the pia, and that region is called subpial region or subpial accumulation. They originate from oligodendrocytes, which is pretty visible from the name, and very common in adults aged 35 to 50, more frequent in males than females, and predominantly frontal lobe. Calcification is common. There's a very particular name for it. I think it's called gyriform calcification or something, because the calcification follows gyri, and that is visible on the CT. Less mass effect than the size would suggest. So they commonly present with seizures, headache, cognitive changes, and focal deficits. This is how we differentiate grade 2 and grade 3. Mitotic activity is very low on grade 2. It is brisk on grade 3, and there is proper microvascular proliferation. This is the thing that is most important in this whole slide if you want to take away only one thing. If there is CDKN2A or B homozygous deletion, the tumor is automatically upgraded to WHO grade 3. And we have to go for aggressive triple therapy in grade 3, and for grade 2 we can delay the radiotherapy and go for wait and watch method. So as I said, CDKN2A and CDKN2B homozygous deletion in grade 3 tumors indicates worse prognosis. Do not confuse this with grade 4 astrocytoma. So this is the gyriform calcification I was talking about. If you see, this is closely following the normal brain gyri, abnormal in this case. And we can see that there is some mass effect here. There is peritumoral edema, effacement of the ipsilateral lateral ventricle. There's herniation as well. This edema is denoting to us that this might be a higher grade oligodendroglioma. If it was a lower grade, the edema would not have been there as much. On MRI, they are typically hypointense on T1. T2, they are hyperintense. And contrast enhancement is variable. Grade 2 usually do not enhance. Grade 3 often enhance. So can somebody do me the honors and read these images? Anybody?
Yes, ma'am. This is the 5 into 5 centimeter. This is the first slide on the left side. This is the axial cut of the brain, T1 weighted image showing the 5 into 5 centimeter mass lesion. And at the left frontal lobe, which also causes the midline shift and the subfalcine herniation, as well, there is a hypointense lesion with the central hyperintensity. And on the right side, this is the coronal cut of the T1 weighted image, which also showing the 5 into 5 centimeter space occupying lesion at the convexity, as well as also going affects towards the FOX midline shift.
Okay, Dr. Mustafa, that was really good. Only one word of caution, never comment on tumor size if you do not see a scale around here. Because anybody who is listening can trap you in there. It's like digging your own grave because you have no idea what the tumor size is since you are not given the scale of sections or anything. So it would
Yes,
be
ma'am.
very unsafe if you do it in rounds or viva. So these are T2 axial and flare. Axial, if you see the lesion is hyperintense on T2, it is still hyperintense on flare, and the core is hyperintense as well. The core is not changing to hypointense, which was the T2 flare mismatch sign. So this imaging pattern is showing us that this is an oligodendroglioma and not an astrocytoma. So these
Yeah,
are the
please, excuse me, please repeat that T2 flare mismatch thing in the
okay.
previous slide.
Sure. Dr. Burhan, T2 flare mismatch is when a lesion is hyperintense on T2, but when you see the same corresponding lesion on flare, it's not hyperintense in the center. The core or the central region is going to be hypointense. The periphery is still going to be hyperintense. So if you see in this lesion, this here is hyperintense. This still here is hyperintense. It's not automatically getting hypointense. So there is no T2 flare mismatch sign. I'm not sure if you remember the image from astrocytomas where it was,
There is a mismatch in the core, right?
yeah, we see for the mismatch in the core.
In the
This
core,
is,
जहाँ पे you are
yes.
pointing
Can
this
you see my
mount.
pointer?
Yes, this area has got the mismatch, and the surrounding has not got the mismatch, which
No,
is
this area does not
actually.
have the mismatch because this is
Yeah.
hyperintense on flare and this is
Huh.
hyperintense on T2 as well. So there is no
So what does
mismatch.
that mean? What does that flare mismatch mean? Any diagnostic
If this
point
was
that?
hypointense and the
Hmm.
periphery was hyperintense on flare, then it would have meant that this is an astrocytic tumor.
That
T2
is
flare,
typical of flare
yes, that
mismatch, which is typical of astro.
it is typical for astrocytomas. It's used
Which
as a
grade?
differentiating radiologic sign to differentiate the oligodendrogliomas and astrocytomas.
Which grade of astrocytoma, or
That
generally?
generally, that's a very general rule.
So this is not astrocytoma,
No, this is not astrocytoma. This is oligodendroglioma.
because the center should have been hypointense, and
Yeah,
surrounding should be hyperintense.
yeah. I can send you the T2 flare mismatch slide from the astrocytomas after this session.
Thank you.
Okay, so moving on, we can see the contrast enhancement. It's patchy at best, and we can see some central cystic sort of areas here which are signifying necrosis. So, summarizing this session, we have NCCN 2025 guidelines. For WHO grade 2, we divide them in low-risk groups and the high-risk groups. The low-risk groups are patients who have favorable prognostic factors. For example, complete resection, younger age. In these patients, observation or enrollment in a clinical trial may be recommended. High-risk patients, and okay, one word of caution because I think I forgot to include it here. We are talking about this entire thing after the surgery. Maximum safe resection is non-negotiable, right? After maximum safe resection, or in this case, we are saying that we have done complete resection, the patient can be enrolled in a clinical trial, or we can choose to do observation. High risk group, patients who have higher risk of progression, that is, they have undergone subtotal resection, they are older age group, and in these patients, standard radiotherapy with adjuvant PCB chemotherapy or temozolomide. For grade 3, we are again going to divide these on the basis of KPS score. If it is more than 60, standard radiotherapy followed by adjuvant TMZ, or the standard radiotherapy followed by adjuvant PCB. Poor performance KPS, if it is less than 60, then treatment options might be palliative, including hypofractionated radiotherapy alone, or we can choose to give chemotherapy alone.